All right. Welcome to my conflict resolution presentation. Let me know if at any point you can't hear the sound or can't see the screen. I'm excited to talk about something we really need all over the place these days, let's be honest, right? To be able to communicate, to be able to peacefully disagree, to be able to be curious about perspectives, opinions, that differ from our own. So let's get started. I have no disclosures, no financial conflicts. I based a lot of this presentation on nonviolent communication techniques. And there's a great book. I have it here. I have it, the Nonviolent Communication book by Marshall Rosenberg. And it also has a companion workbook. I think it's a great resource. Emotional regulation and attunement to your own needs is key. We're also going to discuss reflective listening and motivational interviewing and some de-escalation. So nonviolent communication is very deceptively easy to learn the concepts and much more challenging to put into practice. It includes 4 major stages: observing without evaluating. So saying what people are doing that we like or don't like and how it impacts us, expressing how we feel about what they're doing, and expressing our needs and making a request from the other person that includes a concrete action. So easy, right? Lots of things get in the way of compassionate communication: judgment, criticism, not taking responsibility, labeling, needing to be right is a big one. Marshall Rosenberg says people who seem like monsters are simply human beings whose language and behavior sometimes keep us from seeing their humanness. This is an actual Looney Tunes monster who's actually kind of sweet. Communication that alienates us. So Marvin the Martian here is very focused on right and wrong. He's in a judgy place, right? I am right, you are wrong. Analyzing people's level of rightness or wrongness and who deserves what. When our attention is focused on judgment and figuring out who's wrong and who's right, we lose compassion. So here in this example, medical assistant talking to the doctor, "You're so picky and neurotic." Doctor, "You're sloppy and disorganized." Gerald Jampolsky is a doctor who has a quote: "You can be right or you can be happy." So the goal here is to focus on what we need instead of passing judgment on the other person. Marvin the Martian here is asking for help. Medical assistant, "I need acknowledgement that I'm working really hard here." Doctor, "I need to trust that the blood pressure written down is accurate." Observing without judgment is tricky. So a judgment is Susan is ugly, whereas an observation is I personally do not find Susan attractive. Evaluation, you don't take care of your health well enough. Observation, if your nutrition doesn't improve, I'm very worried as your doctor that your health will suffer. You don't spend enough time with me. Or the last 3 times I asked you to go to dinner, you said no. Specific, concrete observations. Judgments can sometimes masquerade as sharing feelings. I feel you don't love me. That is a hypothesis versus I'm feeling unwanted, right? I feel you're ignoring me. I feel lonely when you look at your phone. Nonviolent Communication Academy, so there's a website there, has these feelings and needs reference guides. The basic human feelings when our needs are fulfilled, feelings when our needs are not fulfilled, and basic human needs listed out as a resource. I especially think this is challenging as healthcare and mental health professionals because we are very skilled and practiced at focusing on other people's feelings and needs, and can have blinders to our own, especially the ones that are less pleasant or less altruistic, let's say. Feelings are signposts to notify of unmet needs. For example, feeling angry at hospital administration, unmet need for autonomy. Learn to pick up the unmet needs behind painful feelings. And to do that, we have to really embrace some radical acceptance towards our painful feelings. Not easy. The more directly we can connect to our own feelings and needs, the easier it is for others to respond to us compassionately, even when they aren't connected to their own feelings and needs. So we think, I know I need blank because I feel blank. I feel overwhelmed. I know I need some rest. I feel angry. I need some acknowledgement or some respect. I feel resentful. I need more acknowledgement, connection, belonging, maybe needing to pee. There's a saying, emotional liberation involves stating clearly what we need in a way that communicates we are equally concerned the needs of others be fulfilled. And judgments of others are alienated expressions of our own unmet needs. Gabor Mate, who's a primary care doctor, and he wrote, it was in his book, In the Realm of Hungry Ghosts, Close Encounters with Addiction, which is a very good read, by the way, that he wrote that as a doctor, when he is feeling judgment towards a patient, he realizes that the vast majority of the time, that is because that patient reminds him of something within himself that he does not want to acknowledge. So we got to get really comfortable with these painful feels. Anger can be an alarm clock, waking us up to realize that we have a need. And we may also be acting in a way that makes it really less likely for other people to want to meet our needs. So when we hear a difficult message from another person, we have three options. Blame other people for what's wrong, blame ourselves for what's wrong, or sense our feelings and needs and others' feelings and needs, recognize our common humanity, and find a way forward. The blaming ourselves part, I'm going to note that one because with this, nonviolent communication, it can be, I think, misleading that maybe you're supposed to be really, really focused on the needs and wants of others. And then if you are focused on the needs and wants of others, it'll all be good, all work out okay. When the balance is so important. For example, it may be very important for us to recognize and validate our needs. I'm very frustrated that my husband ate the last cinnamon puffy snack that is my favorite cinnamon puffy snack in the house, and I'm irritated, and I tell myself, you shouldn't be irritated. That's a stupid thing. It's your fault for, placing too much emphasis on cinnamon puffy snacks. There's more important things in life, whatever. And I stuff it down and I don't communicate. And then randomly I'm like, why'd you leave this dish out? Because I did not communicate. Because I invalidated myself, because I told myself it was all my fault. So a huge step in this is really not just owning, but validating our own feelings when we're engaging in this communication. And also being emotionally regulated before we try to do this work. It was Daniel Siegel who said, regulate before you relate. I think if there being a scale Where somewhere around, level 4 frustration is where we're reaching the point of relational futility. We are not fit for human consumption. We need to take space before we have a challenging conversation. And it's important then to circle back when things are calmer. We avoid circling back often when things are calm because things are calm. And we don't want to sacrifice that wonderful, comfortable calm. But that's the time when it's time to have really tough conversations. So make sure other people are emotionally regulated before engaging with them. Like the saying, strike when the iron is cold, not when the iron is hot. So we covered observing without evaluating, feelings, sharing related to the needs that created this feeling. Now we're going to go to making requests. Requesting that which would enrich life. Marshall Rosenberg has such nice ways of saying it. He says, when the other person hears a demand from us, they see two options, submit or rebel. So we're trying to make requests, not demands and not threats. So people understand that if they say no to our requests, they won't be blamed or punished. Otherwise, they will see it as a demand. Take time to figure out what it is you actually want from the other person. I really think that's the most important step in all of this, is going into a difficult, challenging communication with someone, knowing what it is you actually want from them. And tell people what you want them to do, not what you don't want them to do. He shares a funny story in his book. A wife was telling her husband, I really want you to work less. Husband signs up for golf tournaments. He's like, look, I'm going to a golf tournament. This is great. And she's like, no, I meant I wanted you to spend more time with me. But she didn't say that, what she actually wanted. She said what she didn't want. Bugs Bunny and Elmer Fudd are now going to demonstrate for us not using needs-based communication, and then they're going to try it again. All right.
Meh. What's up, Doc?
You crazy rabbit! You know what? My carrots and my cabbages is gone. I got you now. You rabbit stew!
But I'm just a starving woodland creature.
Starving, dang nabbit! You a fat rabbit! Can you even fit that gullet in your burrow?
Shut up, Doc. You're a greedy gardener.
Wascally rabbit! I'm hunting you down!
So you see lots of judgments, discussion of who's right and who's wrong and who has a right to what.
Meh.
All right. There's a saying, rather than put your butt in the face of an angry person, empathize. But I'm just a starving woodland creature. And this seems really funny and silly, but these techniques could actually save your life when you're facing an extremely angry person in your office or just out, in life. But I never did that. But I have rights too. But I never called you fat. And our instinct is to defend ourselves and say but. So now we're going to listen to Bugs Bunny and Elmer Fudd doing it differently.
Meh. What's up, Doc?
You wascally rabbit! When I find all my carriages and cabbages gone, I feel scared because I can't sell them and I need financial security. Please let the vegetables in my garden stay till the harvest.
I hear that you need to sell your carrots and cabbages. When I saw you setting traps in the wood, I got scared. I need to feel safe foraging in the woods for food. Please keep your snares out of my woodlands.
So, we see them stating the feelings and the needs they have. And they may not come to an agreement, but they're closer than they were the
Meh.
first time, at least. They've made specific requests from each other. Javier Amador wrote, this is a great book. I Am Not Sick, I Don't Need Help, How to Help Someone Who Won't Accept Treatment. And he says, you will win based on the strength of your relationship, not your arguments. That is the goal here in communication. Strengthening a relationship, not making a point. Circling back is really helpful when there's a really uncomfortable situation. The very uncomfortable situation is going on this slide, by the way. And you don't know what to say. Most of the time, honestly, we are not going to know what to say, and we are not going to be regulated enough to do this in a heated moment. So here's an example of the uncomfortable moment, and then we'll hear Dr. Penelope Pussycat circling back.
Hey, Miss Pussycat, you are looking ravishing. Have you done something to your whiskers different?
Doctor, not miss. I came to get sign out. It's 7 a.m.
What is the hurry? Sometimes a wee bit of stench is worth the chase.
That's my pager. I got to go.
Oh well, there are plenty of fish in the sea, if you like fish. Personally, I prefer girls. Call it a weakness.
And this is a silly example, but sexual harassment in the medical workplace is a serious issue. So Dr. Penelope Pussycat she used the excuse that her pager was going off to escape the situation. Fine. And now she's circling back.
Dr. Lepew, when you comment on my physical appearance, I feel very uncomfortable. I need to feel safe and respected during sign out. Would you be willing to avoid making sexual comment, even if you're joking?
All's fair in love and war. Don't you have a sense of humor?
I'm hearing that you believe it was funny, but it felt very different to me. I need you to avoid making sexual comments during sign out, please.
Okay, sheesh. No more spicy talk at the sign out.
So you notice how unfortunately Dr. Pepe Le Pew does not respond really appropriately to her request. And successful communication does not mean that the other person will respect your needs. Not perfect. Successful communication means that you are respecting your needs by expressing them. So you're judging your success based on how you feel about yourself afterwards, not based on how well that other person took it. I love the book Boundary Boss by Terry Cole, The Essential Guide to Talk True, Be Seen, and Finally Live Free. Now we're moving on to reflective listening. You make a reflective statement. You want me to mark which patients are telehealth versus in-person visits so you know what to expect. Medical assistant, did I get that right? So you comment, did I get that right? You question to confirm. That's very important. To make sure I'm being clear, what did you hear me saying? Very, very often, you find the other person heard something very different than what you said. I use this with patients a lot. What do you hear me saying? How would you summarize it in your words? Okay. And then when the other person gets it wrong, instead of, yeah, no, that's not what I said. Thanks for telling me what you heard. Perhaps I didn't make myself as clear as I would have liked. Let me try again. Reflective listening demonstrates understanding of another perspective. It does not require any agreement with that perspective. So conflict is like a chess match where you're thinking about your next move while your opponent is making their move. Reflective listening means you have to forget your next move and just hear people, which is actually really hard. Simple reflective listening, here's what people are saying. Complex reflective listening, here's what's underneath what people are saying, specifically often the feelings and unmet needs underneath what they're saying. So how does that work? I often get asked this as a child psychiatrist, especially after I've said something that a parent doesn't like. Well, do you have kids of your own? And of course, we want to avoid the defensive response. If you want some parenting tips, you can read a magazine. If you want a thorough psychiatric evaluation, I'm here for you. Okay, right. A simple reflection, it matters to you whether I'm also a parent, is fine. We can also kind of tune our radar for unmet needs and feelings to include those in our reflection and take it up a notch. Psychiatry 2.0. Complex reflection. Are you perhaps worried that if I'm not also a parent, I won't be able to understand what you're going through and I'll judge you more harshly? Maybe you need me to understand how hard this is for you. That's where the gold is there. So simple reflections, repeating, rephrasing. We can do that. Complex reflections require listening to not just the content of what someone's saying, the affect, the person's values, what's really important to them, meaning what they are not saying, but they really mean. And it can also include using metaphors to enhance perspective. That really shows that you get what they're saying. Reflective listening can easily be confused with advising, reassuring, sympathizing, investigating, explaining. So, a statement, oh my God, I've gained so much weight lately, I feel disgusting. Advising, well, you should cut out sugary drinks and exercise. Reassuring, you shouldn't be so hard on yourself. Sympathizing, oh no, I'm so sorry you feel that way about yourself. Investigating, when did you start gaining weight? What are you eating? Or explaining, I never thought you were fat. Versus a reflective listening response is, wow, you are feeling really frustrated with yourself and ashamed of your body right now. And it's tough because we have to sit with people's pain and resist the urge to fix it with the advising and the reassuring and the sympathizing and the investigating and the explaining. Tweety Bird and Sylvester are going to first give us an example of not using reflective listening.
I thought I saw a pretty tat. I did. Bad old pretty tat.
Supper and succotash! A delicious Tweety Bird! I think you'll be good with some seasonings. Maybe some ketchup for a birdie baguette.
You bad old pretty tat. I got every right to live.
Ain't that rich after you'd sick that old bulldog on me?
Poor bad pretty tat. Did he bite your widow tail off?
Okay. Now, Sylvester specifically in the next example is going to engage in reflective listening. So see how he demonstrates he's understanding Tweety Bird, not necessarily agreeing with him, but he's getting what he's saying. Okay.
I thought I saw a pretty tat. I did. Bad old pretty tat.
Supper and succotash! Are you scared I'll do something bad to you?
Yes, I am. You frighten me, putty tat.
Makes sense that you're scared. Can we call a truce, Tweety?
Once a bad old putty tat, always a bad old putty tat.
Are you afraid that because I hurt you before, I'll try to do it again?
Yes, that's right, putty tat.
You don't feel like you can trust me yet.
So you see, he's asking it like a question. Are you afraid because I've hurt you before that I might do it again? Right? Am I getting it right, Tweety? I'm sure he has all the most altruistic of intentions there too. So empathic listening is pretty powerful because it reveals deeper meanings to both the listener and the speaker. Carl Rogers says, When someone really hears you, without passing judgment on you, without trying to take responsibility for you, without trying to mold you, it feels damn good. When I have been listened to and when I have been heard, I am able to re-perceive my world in a new way. So David Puder, I'm a fan of Psychiatry and Psychotherapy podcast, and there's a great episode, Listening Psychodynamically. And I quoted him, "It is not that they are continuing the patient to explore things they know they want to share, but things they didn't even have access to until you listened in a way that reduced shame and fear and therefore allowed them to elaborate and to talk about themselves in deeper ways." So empathic listening reveals things to the person being listened to that they didn't even know as they communicate them, and reveals things to the speaker. It's helpful to think about the needs that people are trying to meet, usually in very frustrating ways, behind difficult behaviors. Demanding. We don't know any patients like that, right? Haha. Fear that needs will not be met. Controlling. Anxiety drives the need to control situations. Denying. Acknowledging a painful truth is just too difficult to them. You can tune your radar for unmet needs in what other people are saying. What unmet needs are underneath the judgments, criticisms, and analyses that get thrown at us? When someone says, "You're so irresponsible with money. I need to protect my family financially." That's typical of you to be so unfair. I need you to understand my perspective. You're totally insensitive. I need you to recognize my feelings as valid. All the other kids have a social media account. I need to feel like I belong with my friends and not get left behind. We can validate and see and understand that need without giving the kid a social media account. You never let me do anything. I need to feel like you trust me. Whoops. All right, I skipped this one. Okay, leading with vulnerability. It's like there's these hard emotions, the shell of the egg, anger, judgment, resentment, disgust. And we want to get at the soft ones. We, as they say, connect with the underside of the turtle. So we're connecting through the fear, the shame, the inadequacy, the guilt, and the loneliness that is there.
What's up, Doc?
First, we look inward. Our pain can block our ability to listen empathically. So often we need to offer ourselves the same quality of presence, attention to our feelings and needs, and validation before we can offer this to others. I like this quote: "The more faithfully you listen to the voice within you, the better you will hear what is happening outside." We can view our painful feelings about our patients, especially, as valuable diagnostic info. Our feelings are part of our psychological physical exam. Who does this patient remind me of? When have I felt this way or acted this way before? When am I treating a patient differently? Who pushes your buttons? And that is really valuable data for us. The ability to know what's happening inside your head at any given moment without getting carried away by it, i.e. mindfulness. I put that on there even though we all kind of know what mindfulness is, because I think that somehow we get away from the definition, which is very simple. We don't have to be meditating to be mindful. We just need to know what's going on inside our own mind without getting completely carried away by it. Being curious aware, non-judgmental, and accepting. The greater our emotional awareness, the greater our self-agency. I bring this up because I think that there was some culture in my medical training that we should not feel negative feelings like anger or frustration or resentment or envy even towards our patients. And that I think that mindset actually harms our ability to be fully present with our patients and use those painful feelings as information about what's going on. As Bessel van der Kolk says, understanding why we feel the way we feel doesn't change how we feel, but it can keep us from surrendering to it. That acknowledgement and full ownership gives us that agency. So, compassionate self-talk. Perhaps my patient is doing the best they can with very limited psychological resources. It's understandable that I'm frustrated because I actually care about this person I'm trying to help. Perhaps I'm doing the best I can with very limited healthcare resources. Perhaps my frustration and helplessness are a clue about how my patient is feeling right now. Very, very common. I wrote this little self-compassion script. And it starts with acknowledging this is a moment of suffering. Suffering is part of being human. I'm feeling a way. How does this feeling make sense? How can I be kind to myself? How can I be kind to others? What would I tell a friend to get that distance from the situation? What lesson does this moment have to teach me? What's within my control that I can change? What is not within my control that I need to accept? Depersonalizing the situation. So asking what you would tell a friend in the situation is one method of depersonalization. Another is taking a step back, as if the situation were happening to someone else instead of you, imagining characters interacting on a movie, for example, like Bugs Bunny is doing here. It's helping him practice his communication techniques. And avoiding telling ourselves should. Shoulding ourselves bleeds our self-compassion, but I should be better at this. But I shouldn't feel that way. I should have known better. Compassion for people and for ourselves goes hand in hand with frustration and irritation with people and ourselves. I think of it like they're opposite, they seem opposite, but they enhance each other. Ice cream and chocolate sauce. Yes, that's how my imagination works. Because holding space with another human being for both valid frustration with them and compassion for them is very enriching, not interfering. Emphasize patient's autonomy. The decision is ultimately up to you. And you can validate a patient's concerns without giving in to them. Identify and align with the healthy parts of their message. Ask permission before giving advice. One of the techniques I stole from the book I'm Not Sick, I Don't Need Help by Javier Almeida was really waiting to give recommendations until the patient is asking for it. So yes, may I share my perspective as your doctor? And there's like, okay, all right, I don't have to share my perspective. You know, are you sure? I'm afraid that it might upset you, and you really wait. And then let's just wait and let me hear your perspective first. Okay, tell me more about what you're thinking. Tell me more about what you think. Okay. All right. And then the patient will ask again, but what do you think, doctor? Yeah, okay, now I'll finally tell you. So you withhold your recommendation until the patient is really like, I want to hear it. Um, so those are some tricks you can learn in those books. Motivational interviewing in healthcare and the classic motivational interviewing, helping people change and grow by Milner. Awesome resources. Um, for someone to change, they need to both have reasons to change. They want it. And they also need to believe they can, have confidence that they can change. So I think about motivational interviewing as, wading through a bunch of weeds to pick out the flowers. Patient says, you know, well, nothing relaxes me like marijuana. It actually helps me focus. My instinct as a physician might be, do you know, patient, that research studies show that people who are high on marijuana will rate themselves as more focused, when in actuality, they are less focused because their perspective on themselves and ability to have insight in that situation is limited. Anyways, that would be a temptation. That would be one thing to say. With motivational interviewing, you notice when the patient says, "Yeah, it would be nice to have my parents off my back." Okay, it's expensive. I gotta clean your. So what I've heard you say, let me know if I'm getting it right, is it would be nice to have your parents off your back. It's expensive. I gotta clean urine. I could apply if you got a clean urine, you could apply for a job and we offer it back. The reasons for change bouquet. And people believe what they say in their own words far more than what they believe that the therapist says or the doctor says. So the goal here is to get them to give their reasons for change and hear themselves in their own words and emphasize them without falling into the trap of defending against their reasons to not quit the marijuana, which would then elicit more reasons to not quit marijuana. Confidence and ability to change, patient says. Oh, okay. You leave it on the ground when they say, I'm not ready to stop. All right, fair. But I could stop whenever I want. Oh, that's great. You can stop whenever you want. And one time you went a week without it on vacation and you did quit cigarettes cold turkey in one time. So, this is uh outside the scope of the whole presentation to summarize all of motivational interviewing. Um, definitely use those resources if you have an interest in learning more, because I think it's great. It's a really great Swiss Army knife. Repairing a rupture in a relationship. Self-compassion is like really huge here because we have to have a high degree of compassion for ourselves to be able to really take in and notice and look out for the ruptures in the relationship with the patient. We need to get really comfortable with patient dissatisfaction and practice non-defensiveness. Encourage patients to openly disagree with you and express dissatisfaction and explain to them how this is helpful for your work. Dr. David Mintz, who wrote Psychodynamic Psychopharmacology, I'm a big fan of that, by the way. He says, patients who cannot say no with their words do so instead with their bodies, i.e., their side effects. Zoloft caused me this terrible side effect because they weren't able to say no to the doctor about something else. So it's very, very important to have patients openly disagreeing with you with their words, and that is relationship cultivating. Embracing our mistakes fully is a major opportunity to deepen the relationship. This is a quote, Michelle Baldwin, from The Use of Self in Therapy. When you have never upset a patient, never had a break in empathy, therapy has lacked power. It is a cream puff. not transformative, not deep enough. Don't be doing no cream puff therapy here. We are not doing cream puff therapy. We are messing it up and owning it. Captain Jean-Luc Picard, it is possible to commit no mistakes and still lose. That is not weakness, that is life. In psychiatry, psychotherapy, and medical practice, when we make mistakes, we can still win. Opportunity for a psychiatrist or therapist to model openness, receptivity to feedback, and self-acceptance of our own flaws for our patient. Opportunity for the patient to experience safety while disagreeing within a valued relationship, encouraging greater authenticity in the relationship. And the opportunity for a patient to learn that conflict and disagreement can be intimacy enhancing. Repairing a rupture, a disagreement, brings us so much closer than agreeing ever did. Which brings us to the final part of this presentation, de-escalation strategies, right? Because it's tough, okay? Really angry people, what do they want? Help, choices, acknowledgement. So de-escalation means preventing aggressive and dangerous situations from occurring and reducing the need for restrictive interventions. A great article is Calming Agitation with Words, Not Drugs. Respect people's personal space. Be aware that personal space for a paranoid, agitated, irritated person is a lot bigger than personal space for a calm person. So for a calm person, personal space is about like 2 arms length away, is really safe. It's going to be greater for someone who's upset. Not being provocative, being concise, identifying wants and feelings, and being firm in limits, offering choices. Before proceeding with an angry person, ask yourself, number 1, is there a path that can allow me to retreat? Number 2, am I being threatened with bodily harm? Number 3, am I confident that I am in a place emotionally right now that I can interact with this individual without being defensive or angry? And don't take the bait. Splitting. But the nurse said da 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 da, right? So check out what what the patient is saying other people have said. Power struggles. So enticing. Personal attacks, challenges, personal questions. We're gonna let them go. We're just gonna tiptoe by that and focus on what's important. Whoops. Severe agitation. So I want to note that there's an average of 8 very serious, like serious means serious physical harm, missed work, patient to staff assaults per hospital per year. And 2/3 of these assaults are triggered by trying to restrain and give the patient injectable sedating medication. So we really want to avoid getting to that part where someone is trying to where someone is attempting to restrain and sedate a patient. That's the biggest thing we can do to protect everyone. And if a patient is sedated, it delays time till people can take a history and get info from that patient, till psychiatry can be consulted, till they can be transferred to another hospital. And from an ethics and humanitarian perspective, we want to avoid causing trauma and having patients view our medical system as an adversary out to get them. So, tips for avoiding this. I'm going to let you listen to this cool vignette that I took from Psychopharmacology Institute.
So I was working in an emergency department at a hospital, and a patient was brought in by paramedics on an involuntary psychiatric hold. He was screaming nonstop. This patient came in and was seen by the triage nurse, and the nurse immediately said, "Let's get the team. We're going to put this person, take them right from the gurney, and we're going to put them into a restraint bed here in our emergency setting." And put them into a seclusion and restraint room, restrain them in 5 points to the bed in the seclusion room. And the nursing staff came to get me and said, Dr. Zeller, we have a patient who's really, really agitated and he's really in bad shape and very incoherent, and all he is doing is screaming. Can you prescribe him intramuscular medications? Can you give him the haloperidol, lorazepam, diphenhydramine cocktail? Because he needs it. That's what he needs right away. And I said, well, did you ask him if he's willing to take medications? And no, he's incoherent. He's just screaming nonstop. And I said, well, I've got to see him before I prescribe anyway, so let me go talk to him. And so I went to the patient room, opened up the door, and sure enough, there's a patient in there screaming, nonstop. And just decided to go ahead and try it. And so I said, sir, when you're having a difficult time like this, is there a medication that might help you? And the patient was, yeah. And he stopped and said, Risperdal. And then, yeah. And so I caught his eye and said, oh, would you be willing to take some Risperdal if we brought you some pills right now and a glass of juice? And he kind of nodded his head while he continued, yeah. So I went and told the nursing staff, and I wrote for him to get some risperidone and a little bit of lorazepam, both in oral forms. And the staff shook their head like I was out of my mind, but they went ahead and took him that and a cup of juice. And believe it or not, he kind of willingly took the medication. They helped him get it into his mouth. He swallowed it down. And about 30, 45 minutes later, went back and he was doing much better. There was no more screaming. There was no more yelling. In fact, they were able to take him out of the restraints, and he was sitting up in the bed. And I went in to see him and said, hey, looks like you're doing much better. It looks like you were really having a difficult time before. And he was able to talk to me at that point. And he said, yes, thank you so much. And I know I was screaming and it might have seemed really strange, but what you don't understand is I was hearing these really awful command hallucinations that were telling me to kill my children. And the only way that I could stop them was by screaming, because otherwise I knew that I was going to feel like I couldn't resist them. So I screamed so that I would not hear these command auditory hallucinations, but these voices to kill my kids. And I thought that was just a really, really remarkable thing. And so that even when somebody appears incoherent and in really bad shape and screaming nonsensically, that maybe there's some logic to it, and that we treat everybody as an individual and realize that people are, even when we think that there's no possibility they're going to be willing to cooperate and take meds, are key points that it's always worth attempting offering oral meds, to attempt verbal de-escalation, attempt calming techniques, because our potential benefits and risk reduction are going to be really well worth it. And also, just because a patient's agitated doesn't mean they can't understand you or work with you collaboratively.
Yeah. So offer oral medicine before trying to inject people. Hey, is there a medicine that helps you when things are like they are right now? The goal of this medication for agitation is calmness, not unconsciousness, so that we can still be communicating with them. So about some oral meds here, okay? Lorazepam, second generation antipsychotics are ideal over old school Haldol. The typical antipsychotics have a lot less side effects. So for example, Haldol, you can get neuroleptic malignant syndrome, neck spasms, have a severe dysphoric, that means a depressive reaction to it. Much more ideal. I am a big fan of olanzapine because it comes as a dissolvable wafer, and about 10 milligrams of olanzapine is pretty much going to make people pretty calm. So, I am not at all adverse to having families outpatient, I'm an outpatient psychiatrist, have this as an option. And family members, children and adults may appreciate having an option of something that they can take to calm themselves. I am much more cautious about benzodiazepines since they're addictive. But I think that there's definitely a place for them. Atypical antipsychotics are going to have a lot less side effects that are preferred over typical antipsychotics. Ziprasidone can be given IM. as an alternative to giving Haldol IM, by the way. And if you're working in a hospital setting, you do not want to combine olanzapine IM or IV with lorazepam. There is some cardiac risk there, just FYI, you'd want them to be spaced out. So, most importantly, as healthcare professionals and mental health professionals, we need to accept that you can do everything right and people will still be upset. Ultimately, we are not here to make patients happy. We're here to help people become healthy. And that means that we are very compassionately facing these issues head on with our patients. So, strategies for the long haul. Be firm with your limits and boundaries. Easier said than done, by the way. You may need to lower your treatment goals to more smaller, realistic, attainable goals, decompressing the treatment timeline, like years instead of weeks, okay? Having a team approach, being aware of splitting, having colleagues who are, you're selective, you're picking the non-judgmental, emotionally astute colleagues who you can vent to when you're feeling overwhelmed and hurt for support. And so you vent, you like tell them the story, they validate it, and we call that co-regulation. You can use each other to regulate your nervous system. Give each other feedback in non-judgmental yet constructive ways as we're all learning. And stay curious. So feel free to share this presentation. This is the cool new YouTube channel that my husband made me. I appreciate people listening, and also feel free to reach out. I like hearing from people. Comments or complaints. I'm gonna stop my video and take questions, and I will turn off the recording. I will do that. Pause/stop recording.